Yeah, so we are, very lucky now, or the patients are very lucky now to have bispecific antibodies at their arsenal and readily available. That includes teclistamab and now recently approved elranatamab and even talquetamab, which is targeting GPRC5D. So having these options in the clinic have really been transformative for many patients, honestly, that cannot either tolerate CAR T-cell therapy, wait for CAR T-cell therapy manufacturing, or simply just don't have availability of that particular product. Which ones do we prefer? I think it's still a bit unclear what the right sequence is, whether you pursue CAR T-cells followed by bispecifics, vice versa. At this point, cilta-cel or Carvykti, comparing all the approved products, seems to have the highest overall response rate and the longest durability of response based on some of the early phase studies that we've seen. We have to see this play out in the real world, and right now, because of the supply constraints, we have been able to essentially, treat many more patients with bispecific antibodies than we do with CAR T-cell therapy, simply for a myriad of reasons. So I think they all will have a space. It just depends on the particular patient profile, whether the patient's disease kinetics can wait for CAR T-cell manufacturing, and then there is some differences in toxicities in terms of the rates and severity of CRS, risk of infections, and a few things that we discuss with patients when making this decision, but it's nice to have all the options.